The FS200 has a number of additional capabilities to the flap making that it's usually used for. It can create customized LASIK flaps, so we can alter the geometry of our flaps. It can create corneal pockets for inlays such as the camera implant or the raindrop corneal inlay. It can create tunnels for corneal ring segments, such as the Intax or the Kera ring. And it's probably this that is the additional usage that gets most work in our clinic. It can be used for arcuate corneal cuts to alter astigmatism. And it can be used in corneal grafting. It can be used for full thickness corneal grafting with modified peripheral shapes. And it can be used for femtolamellar grafting. So let's have a look at some of these options that we've got. So normally we'd have a round corneal flap. We've got the option to have an oval flap. We've got an option to alter the hinge position and angle. And these can be useful with smaller corneas, corneas with small corneal scars, corneas with a lot of micropannus that might cause some bleeding under the flap. So we've got a lot of versatility in this, although this is still using it in its conventional role as a flap maker. We can cut a corneal pocket. We don't have to actually cut a side channel, and we can cut a corneal pocket, which, as you can see, can have a nice large entry tunnel to slide an inlay into position. Some of these are not in that much use at the moment. The camera inlay I used several years ago and don't use them currently. But as additional inlays are developed, if they are, we've got a route to put them into position at a suitable depth, typically about 200 microns, with minimal corneal disruption. Let's have a look at how we might use the FS200 to plan and place a corneal ring segment. So here's a keratoconus patient, quite a significant inferior steep cone, and we've got a plan from the manufacturer for a 160 degree ring segment, which is going to go inferiorly as shown on the black and white diagram on the right. So we bring our planning software up with this in position. We utilize either the suggested manufacturer's data. So we've got inner tunnel diameter, outer tunnel diameter. We've got a little access, which is that rectangular portion of the ring, and that will be our incision and pocket, which allows us to enter the cornea to place the ring. That doesn't have to be aligned with the axis of the ring. You can move it back a little bit from where the ring is going to position itself so that you've got more corneal seal to isolate the ring. Placing, docking and firing the laser for these ring segments is an amazingly easy procedure, certainly compared to any manual corneal dissection. The inlay gives a beautiful, well-illuminated view of the anterior segment so that you can get good alignment over the pupil or the apex of the cone according to your preference. And it's a very, very quick laser firing. I'll show you it shortly. So let's have a look at the laser in action. So you can see us cueing it, we've centered it, and there's the ring cut. It's as quick as that. There's a slow motion replay of it, and you can see it takes 6 or 7 seconds. It really is a quick procedure, very easy for the patients to tolerate. And now you can see the printout we get, and we get a static photograph of the tunnel as created. Let's have a look at the surgical procedure of inserting this ring. So we've got the plan next to us, which we keep inverted because we're looking at the patient from the top. We put a spatula in to open the ring tunnel, so we've got an entry. We lift up the ring and insert it gently. And then there's a little bit of surgical geometry involved in feeding this round, because you're pushing it from above, and yet it's got to travel left to right. But that's the same with putting in any ring segment, and just takes a little bit of practice and a little bit of patience. But the tunnel does open up beautifully. I find I don't have to put a corkscrew spatula in to open it. I just slide the segment in. And a bandage contact lens usually concludes that. I just go back and finish on this. So as you can see, a very elegant solution for ring placement, and as I say, probably the main additional use that we utilise the FS200 for in our clinic. Acute keratectomy, patients left with a degree of astigmatism, post-cataract surgery perhaps, or post-corneal scarring. And an acute keratectomy is a very well-established way of reducing astigmatism. So you can utilise any of the standard nomograms. You can set these keratectomies that go completely through to the epithelium and are easily opened, or you can actually even set them so that you have one just short of the anterior epithelium and stroma, and you can come and open one or two at a time, depending on even a few days later if required. Femto-assisted PK, corneal grafting, is a really interesting area that I think will probably gain momentum. The idea of having not just a vertical cut through the cornea, but as you can see here, a staggered or Z-shaped cut is very advantageous. You can bias your corneal transplant towards either more of the epithelial surface, which you might choose in, say, a patient with keratoconus but a healthy endothelium, or you might bias it towards more endothelial coverage in patients with diseased endothelium, such as Fuchs, in which a lamellar graft is not, such as a DMEC, is not appropriate. So very versatile. I like the idea of the increased strength that is potentially possible through this dovetail effect. And I've done just a handful of these femto-assisted PKs, but it is a great tool. You have the option once again of completing your cut right through to the epithelium if perhaps your FS200 is located in or adjacent to your theatre. If, as we face, we have to travel across town, or a patient has to travel across town, you can leave a significant tissue bridge to leave the anterior chamber intact, and then you can simply complete that with a diamond knife at the time of the surgery, and you've still got your profile cut. Of course, you cut a matching profile on the donor cornea mounted on an artificial anterior chamber. There's a enlargement of the profile that I've planned here. You can see this one doesn't go through to the corneal surface. It starts within the anterior stroma, very anterior stroma. It continues on well through the endothelial segment, which may look a little odd, but that's so you get complete clearance and a complete cut. And again, the same on the donor cornea. Femto-anterior lamellar keratoplasty is also possible. An alternative perhaps, or a companion to a big bubble DMEC type procedure, particularly appropriate where you have a anteriorly based corneal scar where the posterior cornea is relatively healthy and we don't want that to be disturbed, but perhaps it's too deep a scar for a PTK perhaps to remove. An anterior lamellar keratoplasty is possible, and again one can dissect both the donor cornea and the recipient cornea using the FS200. So in summary, the FS200 is more than a simple adjunct to a LASIK suite making flaps. It's really a sophisticated corneal surgical tool. that's got a lot of aspects to it. You can customize your flaps, you can use corneal pockets, you can very elegantly use tunnels for corneal ring segments. You can use it in the setting of astigmatism, you can use it in the setting of corneal grafting. And I think we will discover more and more varied uses for this surgical tool as time goes on. Thank you.